Headaches are extremely common and usually not associated with serious disease, even though they may take a recognizable form. For example, in migraine, they may be one-sided and accompanied by visual symptoms, such as zigzag patterns in the field of vision. Cluster headaches, recurring over a short period, may be severe, one-sided, and associated with excessive tearing. The face may be puffy and the nose blocked. Tension headaches present with a dull aching pain and a sensation of tightness within the head. However, patients presenting to an ophthalmic service must have a careful history taken. They must then be thoroughly examined to detect or exclude serious disease. Sometimes headache can be a real diagnostic problem. We will discuss some of the more important causes. A few points for consideration. If headache is generalized and variable, a cause is often not found. Consider eye strain associated with excessive computer use and check for refractive errors. If headache is one-sided, severe, and recent, first of all exclude obvious intraocular causes such as acute glaucoma and anterior uveitis. In both cases, the eye will be red and the vision probably blurred. If the eye itself does not appear to be the source of the pain, then think of the following. One-sided scalp tenderness in a patient over 60 is an indicator of giant cell arteritis. Look for other symptoms of pain when eating, called jaw claudication, shoulder pain, and feeling generally tired. The patient may also report loss of vision as the optic nerve loses its blood supply. An ESR or CRP test should urgently be performed on that day, and if the diagnosis is thought likely, particularly if there has already been loss of vision, then steroids should be given intravenously. If cranial arteritis is missed, it can lead to blindness. If quite marked pain is accompanied by a rash, then consider herpes zoster, ophthalmicus, and look for the familiar vesicles and redness. The picture shows these are strictly limited to the distribution of the trigeminal nerve and involving the scalp on the affected side through the frontal nerve. Sometimes the skin of the nose may be involved through the nasociliary nerve. This is a warning sign of intraocular involvement, such as uveitis. Pain caused by inflammation in one of the sinuses, termed sinusitis, can be mild to severe. There is often tenderness over the affected sinus to palpation. This may lead to orbital cellulitis. Radiography or imaging studies will help to establish the diagnosis. A mild unilateral headache may accompany optic neuritis. This is often worse with eye movement. Usually the vision becomes increasingly blurred over a few days. There may be a past medical history of multiple sclerosis, or the patient may report other neurological symptoms, such as weakness or loss of sensation in a limb. On examination, there will be an afferent pupillary defect, and a field defect may be detectable, particularly to a red target. A sudden severe headache that may be accompanied by nausea and vomiting, neck stiffness, and double vision may indicate a ruptured intracranial aneurysm. This is life-threatening and requires urgent neurological review. Meningitis, an infection of the tissue layer surrounding the brain, may also present with a severe headache. A fever, together with nausea, vomiting, and neck stiffness, points to the diagnosis. In some cases, a skin rash may be present. This too is a very serious problem requiring immediate treatment. A generalized severe headache may indicate raised intracranial pressure. This may be accompanied by other neurological symptoms. Double vision may be present if the cranial nerves are involved. A sixth nerve palsy is particularly common. There may be no visual symptoms, although some patients may complain of momentary visual loss and changing posture from sitting to standing. termed an obscuration. Urgent neurological investigation is required. Younger patients may have an elevation of the pressure of fluid surrounding the brain. This is of unknown origin. This can sometimes be associated with certain medicines, such as tetracycline. Intracranial tumours can also present in this way. A good medical history is important. Severe systemic hypertension or a hypertensive crisis may be associated with severe headache. The vision may be blurred, and there may well be other symptoms. Examination of the eyes may show a hypertensive retinopathy. The key is to measure the blood pressure. The lesson is to be careful with someone complaining of recent headache, particularly if severe. It may be a sign of serious disease. Careful and thorough history taking and examination is essential if the cause is to be found.